On our favorite doctor who is pastime. I don't know if it's a pastime or it's become kind of full time for Dr. Peter Lombard to crunch COVID numbers. Good morning, Doc.
Good morning.
Good morning.
I'd always love to get you on, maybe once a week, every other week, to tell us what you're seeing when you're looking at the latest numbers crunching COVID. So go for it, Doc. What are you tracking here with the latest batch of results?
I could hear what you guys were talking about there right before I came on.
Yeah.
We're nowhere near 200, that's for sure. Even if you look at all the testing around, I think in the low, we're probably averaging around 100, 120, if I had to guess, per day, if you take all the testing into account.
So Dr. Lombard, is 100 is that 280?
That's certainly not.
Oh.
Yeah, so it is good to see. I think our community testing still move forward. As you know, any single case that we get is worthwhile for us to continue that. And it's just frustrating not to know any other details about the most recent cases. The situation reports is a huge improvement, and I think it would be very easy for them to they could just list the cases by numbers, especially the recent ones, and say, approximately how old is this person? Did they or did they not have symptoms? Did they have a contact with a positive case? And how long ago was that? If they were found by contact tracing, but it was 3 to 4 weeks ago and they're asymptomatic, that's a huge difference than if they're symptomatic and they don't know where the person potentially came from. And how bad are their symptoms too? You look back at the numbers. We haven't had meaningful hospitalizations like over 2 or 3 since early April. That's a long time now. And we've had probably 30 to 40 positive cases since then too. 30 to 40. And, at least in the early days, we would say, 20% of your positive tests should be hospitalized. That's the number we were looking at. But that was in the height of the pandemic when we're testing really the sick people, and there were a lot of sick people around. 20% of those would be hospitalized, and 5% of all patients would be in ICU, and they're critically ill. So the number of 40, obviously we expect to see a few people that are sick enough to be hospitalized, and there have been a few onesies, twosies here and there that have shown up on the hospital report, but we don't know necessarily if they were just kind of being monitored or how critically ill they really were. And we certainly haven't had, as far as I know, we haven't had anybody that's been critically ill. So it says something potentially about the positive cases that we're getting. Are they, if they're in the younger cohort, if they're asymptomatic, and if they're potentially even already recovered, and we're just picking up dead virus in these folks. I still think it's worthwhile to do the testing though. You've got the testing capacity, and I don't know if there's still active disease in the community. I heard at least one of the cases recently was symptomatic, but it doesn't necessarily tell us if they're symptomatic from COVID or something else, something new, and they've already recovered potentially. I was thinking one interesting thing to do would be to, we've talked about serology testing and the usefulness of that. Well, since we're only getting 1 or 2 positives on the throat swabs, the PCR testing, why don't we just run them on a serology test? If they're positive with IgG, then we know it's old. We know it's at least 2 to 3 weeks old, and we can say, let's not put them in as an active case. Let's put them as a recovered right away.
Yeah, I saw that in the Philippines, Doc, the way they break down their numbers. They have what they call like fresh cases. And then you should check it out. And they have, I don't know, the other categories maybe like old cases, but it's along the lines of what you're talking about, where the older cases are done with the IgG, so they don't list them as active yet.
That's interesting, and that's states in the U.S. are coming under fire because they're mixing and matching their serology results with their PCR results. If you've got again, we were showing 30 to 40 positive cases in the last month or so, but that's not really necessarily a reflection of how well we're containing the virus. So I think hopefully there is a way that we can reflect that on our reporting that makes more sense. So it'd be interesting to see as more of the serology results come out. But I heard Dr. Nguyen talk about a small pilot study The numbers seem pretty small, but if there are other, private groups doing serology testing, it'd be nice if we could see what those numbers are looking like.
Have you heard that there are people doing private clinics doing serology?
I have heard of private companies that are requesting to do serology testing, and DLS to me is the best serology test right now. They use the Roche system, and it's very accurate compared to the one of the first ones that got approved was the Celix, which I believe is the one that MedFarm has. But unfortunately, the accuracy is really not so great there. But so I do know of companies that have done it, but I don't know any other details.
Mm-hmm.
What do you make of that situation report? That's something that Bree has really been going in on daily. We had Dr. McLaughlin from Public Health on last week, and she was saying that if you want verses, then check the JIC report, but if you want the Bible, the SIT report on Public Health's website is where it's at.
Yeah, like I said, it's a huge improvement. It came out a couple months after the pandemic hit us, but really there's only just a few pieces of extra information I think would be most useful to us at this point. But yeah, it's very valuable, and I'm glad that we have it.
The only thing I have issue with, with the SIT report is the fact that you can't go back to previous SIT reports to make the comparison. So like every day you have to print it out or save it somewhere and then compare it to the one that's released the following day.
And that's where Bree will get a lot of our info is she keeps track. She looks at all the categories and she'll track an increase in a category from the day before, but not because they're collating that data on the website, but because she's keeping track.
You really have to like figure it out yourself.
You need a data guy. Why don't you have Jason do all that for you?
He only likes geeky data stuff.
That's kind of, that's what I was doing with the JIC reports every day. I would take the numbers and I put them into a spreadsheet, and I'm still doing it.
Once you go back, can you go back and use the SIT report data?
You have to find it. Because I don't see, there's no way.
I know somebody who has it.
Every single day?
Yeah.
Okay.
Don't you have it?
No, I don't have every day. I only started like a week ago when Dr. McLaughlin came on. She's like, we have the SIT report.
Yeah, well, they could maybe
produce. We have to FOIA. We'd like the SIT reports.
We'll ask.
Yeah. Well, they're probably keeping some really nice looking spreadsheets too that, for whatever reason they're just using for their own purposes, which I think would be useful for the public to be able to see those as well.
Doc, what do you make of these couple of cases we had in the last few weeks where we're seeing younger? There was a 12-year-old boy that tested positive. He was brought into GRMC, was symptomatic with the fever and flu-like symptoms. Then his grandpa was tested. He was asymptomatic, and then we just had one yesterday, right, Bree? In the 10 to 19-year-old category.
Yeah.
Well, thank goodness it's the younger folks that are showing up, because they're obviously the ones that are going to be able to weather an infection a little bit better. Maybe it means that in households, people are trying to protect the elderly a little bit, because if they get active infection, those are the ones that are going to be showing up really sick at the hospital potentially. So that's I guess the only good news about this. I without having more information, though, it's really hard to speculate on why this is happening and how recently they may have been infected, whether or not their current symptoms are related to an actual COVID infection, or if it's completely unrelated.
Yeah, I think the latest case, and they don't tell you, when we had the 2 positive cases from earlier this week, they don't tell you which was it the young kid or was it the older woman, and was it the one that was connected to the significant cluster, and where is the significant cluster other than that's in northern Guam, right? So,
right. And I have seen on other state websites, public health, they actually kind of every positive case they kind of keep a running. This is case number 155, and they're 58 years old, and they give those kind of details, and you can go back and look at that. And I think what's kind of cool about that is that many people have said this is all hands on deck, and if you have that kind of data out there, then you're going to get interested parties looking at that, and they may be able to put things together and help the situation by making some little discoveries about trends and groupings and things like that. So
Mm-hmm.
it doesn't seem like it'd be a lot of extra work, but they've got a lot of stuff to do. I know,
Mm-hmm.
and maybe it's just a priority that's not high enough for them.
Right.
Mm-hmm. Have you heard about that eMocha app that Public Health has launched to help with the contact tracing?
Yeah, I think she first announced it at a press conference maybe 2 weeks ago now, and
Mm-hmm.
when she did, I went online to kind of take a look at it and see what it was all about. It's vetted by they've used it with other infectious disease before, so I'm sure they'd have to modify it to some degree for the COVID situation, but. I don't know. I haven't heard of anybody that's used it for COVID and how useful it's been, but I'm glad they're looking at something. I've kind of always wished they had sort of an IT champion within their group that's willing to look at that and other means to try to help with the tracing. So I'd like to see it rolled out and see what kind of really results we get. I mean, it's obviously not going to be useful for us if we don't have cases either. And that's hopefully where we stay. But we're going to get more cases. It's just a matter of time before somebody comes in from our file, and once those flights start coming in.
Mm-hmm.
Doc, wanted to switch gears just a little bit here as we've reopened a lot of things. Are you seeing an influx of patients in to see you? Maybe people have been putting things off for the last couple months.
I have to say, like our numbers are still down a little bit, and I think one metric for me are the numbers of surgeries that I'm doing, and we had a backlog because we kind of shut everything down for a little while, but even we're getting caught up, and it looks like we're slow now, moving forward. So I think people still are fearful to go out in general, and still not getting the care that they're not going to their doctors or to the hospitals as often or as more frequently as they used to.
Right.
And that's I don't know if it's been discussed before, but you talk about utilization of healthcare services and the people that pay for that. I mean, most of our healthcare is paid for. A lot of it is by private health insurance companies, and you have to wonder how much they're bringing in right now because they're still getting their premiums, but their subscribers aren't necessarily using the healthcare services. So, it'd be really cool to see at the end of the fiscal year for them to say, hey, here's a little back to the folks that are paying for that, which is mostly businesses. I've heard of them doing that in the States in various places. So just an idea.
Right, Doc. Yeah, we'll put that out there. Thanks, Doc. We got another Doc who's probably a little busier than you because people just don't stop making babies on our island. We'll bring on Dr. Shea. So thank you, Dr. Lombard.
All right, thanks for having me.
Take care.
All right, wash your hands.
Bye-bye.
Okay. There you go. 6:52, and let's keep it going with the white coats. The white coats are coming. Dr. Shea, good morning.
Hey, good morning, Chris.
Well,